is Dr. Debbie Morris, and we are on to the next lecture in the cardiovascular module of our physiology course. As I've said, this is probably one of the most important modules, although as you'll see as we move through physiology, everything connects to everything else, but understanding how the forces created by the heart and the ability of the vascular system to maintain homeostasis in areas of pressures and of fluid balance. Um, this connects to everything else, to the brain, to the kidneys, certainly to the information we've talked about concerning water and fluid compartments. So let's move on a little bit away from the pump, although there are things we'll be talking about having to do with the pump, and then into the vascular system. So you all are aware that the circulatory system serves every organ in the body. That's what I was saying. It's what connects all of those organs in a lot of ways. So it's the circulatory system that transports nutrients and oxygen to cells and organs, and it transports waste products away. Oxygen is carried using a protein slash chemical called hemoglobin that is manufactured within red blood cells and is extremely important for the carriage of oxygen, and we'll talk a little bit more about that in a future lecture. Carbon dioxide is transported using a couple of different mechanisms, and again, we'll talk about that as we move forward, because carbon dioxide is extremely important even as a waste product in maintaining certain homeostatic mechanisms, and particularly in the acid-base system that we'll talk about after we talk about lungs and kidneys. Blood transports hormones. That's sort of the definition of hormones, that they are chemical messengers that are transported in the circulatory system. The circulatory system is involved in temperature regulation, again an area of homeostasis quite important to the maintenance of the health of the human body. So it's blood in peripheral capillaries. If the capillaries near the skin are open, we're able to lose heat through the skin. If the capillaries near the skin are closed, we preserve heat. So the circulatory system is actively involved in temperature regulation. And then again, it's extremely involved in a number of mechanisms that maintain homeostasis in the volume of fluid, particularly in the circulatory system, in posture, in pressure, blood pressure, and in our ability to maintain normal activities. I believe we've had this slide before, which is just sort of a infographic showing the differences between arteries and veins, how arteries, as they decrease in size, have somewhat different construction of their walls. Veins, as they increase in size, again have somewhat different construction of their walls. You can see again, and I mentioned this in the last lecture, that what is the same for all vessels is that they are lined with a tissue called endothelium, and that at the capillary level, the capillaries are a single cell layer thick, and that cell layer is epithelium. Now, I didn't talk about this so much in the first lecture. We mentioned a concept called cardiac output. And I said that cardiac output was a volume of blood per unit of time that is pumped by the heart. So that volume is generally the time is usually a minute, and the volume is in liters. And this is one of those few formulas that I expect you to remember. Cardiac output equals stroke volume, and that would be in milliliters, times heart rate per minute. And if your stroke volume is, say, 100 mLs per stroke, and your heart rate is about 50 beats per minute, your cardiac output is going to be 5,000 mLs per minute, or 5 liters per minute. So this is a formula you have to remember. Cardiac output equals stroke volume by heart rate, and is resulted in milliliters or liters per minute. What comes into the heart is what leaves the heart. So in the big picture, not necessarily second to second, cardiac output is the same as venous return. So the blood coming into the right ventricle from the vena cava per minute is going to be about the same as the blood pumped out into the pulmonary system, and is going to be about the same as the blood pumped out on the left side of the heart into the systemic system. And there's a little bit of kind of second to second and minute to minute variability that results from assorted homeostatic mechanisms. This diagram shows the heart and how the blood is distributed within the heart and the vasculature. So at any given time, about 7% of the blood is in the heart and about 9% is in the pulmonary circulation. The rest of it is in the arteries and the veins, and it's important to know that there is more blood on the venous side than there is on the arterial side. So here, 64% of the blood is in the veins and venules and venous sinuses, while only about, here we have, say, 20% in the arteries and arterioles and capillaries. What's going on this side is under high pressure and is moving rapidly, particularly in the large arteries. What's going on this side is at low pressure and low flow rates. So it's important to quickly distribute oxygenated blood to the tissues. It's okay to take time to return the deoxygenated blood back to the pump. So we have high pressures on the arterial side and low pressures on the venous side. We have the majority of the blood on the venous side compared to the arterial side. And we have rapid flow in the arteries, which then slows when we get to the arterioles and capillary bed in order to give some time for oxygen to be released into the tissues. If you look at blood pressure, it decreases as we go further from the left ventricle. So if a normal systolic blood pressure is about 20 and diastolic is about 80, as you get away from the aorta into the large arteries, say the arteries to the arms and the legs and the kidneys, that blood pressure is closer to 100/60. As we move into small arteries, it drops off even further. And then there's a pretty rapid drop off through the arterioles and slowing in the capillaries. And then very low pressures when we get to the venous side, so that pressure without the variation. That's the other thing. And the arterial side, you have this difference between systolic and diastolic pressure. By the time you get to the capillary bed, that is minimal, and on the venous side, it is absent. There is no contribution of the pump to a pressure differential, and the pressures are very low on the venous side. So the further you get from the left ventricle, the lower the pressures are. There are some organs that get a whole lot of blood. And let's look at that for a minute. Obviously, 100% of the blood that comes back to the right heart goes through the lungs. So the lungs get 100% of the blood. They need 100% of the blood because this is where gas exchange takes place. The heart muscle, which is a pretty small organ, uses a significant amount of blood because it is a high oxygen demand organ. The kidneys get something in the neighborhood of 20% of the blood flow, as does the gastrointestinal system, maybe a little more than 20% on the gastrointestinal side when you include kind of stomach, gut, spleen, and liver. Bones, skin. The brain consumes a pretty large proportion of blood flow and oxygen, as does skeletal muscle. So if cardiac output is 5 liters per minute, more or less, and you'll remember that in the human body there's about 5 liters of blood, so we're really circulating our blood fairly quickly. 100% of it goes to the lungs, about 20% or a fifth goes to the kidneys. So the kidneys are getting about a liter of blood flow a minute. And these tissues, blood flow to many of those tissues, is regulated by adrenergic receptors in the smooth muscle of the vasculature, which allows regulation of blood flow to various organs. So obviously alpha 1 adrenergic receptors in the blood vessels to the skin, when they are triggered, are going to decrease the amount of cardiac output that goes to the skin, while beta 2 receptors in the smooth muscle of the muscular system will dilate those vessels, those arterioles particularly, and allow an increase in blood flow to muscle. So there's constant input from the autonomic nervous system, particularly the sympathetic arm of the autonomic nervous system, to help redistribute blood to organs as needed. So the aorta and the large arteries transport their blood under very high pressures and with rapid blood flow because these are large diameter vessels. If we were to go back to one of those earlier slides, and I think I've got more of these, you can see that these the aorta and the large arteries have a significant structure. They have a number of layers, they have a lot of smooth muscle, they have a lot of connective tissue, and that is to allow them to tolerate the high pressures and a rapid flow that are happening on that arterial side. The adrenergic control over blood flow is primarily at the arterioles, and that's because the arterioles are the major site of resistance within to flow within the circulatory system. So the smooth muscle in the arterioles is under sympathetic control, and it can relax and dilate the vessel, decreasing resistance, or it can constrict and narrow the vessel, increasing constriction. And again, as I mentioned earlier, there are alpha 1 adrenergic receptors in the skin vessels and in the gut vessels that cause constriction of arterioles, decreasing blood flow to the gut and the skin during sympathetic output, when we need it, when we are afraid, or when we are excited. And there are beta 2 adrenergic receptors in the smooth muscle of the vessels to the muscle, to skeletal muscle, that cause those vessels to dilate and allow more oxygen and blood flow to be distributed to the muscles during an episode of sympathetic output, fear or excitement. Once the blood gets to the capillaries, that's where the exchange of substances takes place. So in the capillaries, we have water and gases and many solutes, including ions of the various electrolytes, but also small molecules like glucose and amino acids and other nutrients that are exchanged out of the blood into the tissues and out of the tissues into the blood. Now, I mentioned earlier how most of the blood actually is on the venous side, and the venous side is sort of a capacitance vessel. It stores some blood. It's a reservoir of blood. And if we have a sudden need for an increase in blood flow, where does that blood come from? If we're to increase cardiac output, we have to increase venous return, and it's this kind of slow-moving blood on the right side in the venous system that supplies that increased venous return. In the pulmonary circulation, we exchange gas. That's the main thing that's going on there, although there are some other homeostatic functions. But this is where oxygen is allowed to diffuse into the blood and bind to hemoglobin in red blood cells, and carbon dioxide is allowed to diffuse out of the blood to be breathed out. So again, if the total blood volume in human is about 5 liters, almost 2/3 of it is on the venous side at any given moment. So this is where we're holding blood in reserve. If we have a big sympathetic output, we're going to get constriction not only in the in the skin and gut, diverting blood flow to skeletal muscle, but we're also going to have some constriction of the smooth muscle in the venules and the veins that will push blood back into the heart, increase venous pressures, increase venous return, allowing for an increase in end diastolic, systolic volume and pressure that is preload, and that increases cardiac output. So we'll have a bigger stroke volume along with a faster heart rate. Cardiac output equals stroke volume times heart rate. And so if you have more blood coming in and more blood going out, along with an increased heart rate from sympathetic flow, you're going to get an increased cardiac output. So here, slightly different numbers. So, but again, showing that you have a majority of your blood on the venous side. Some in the heart, some in the pulmonary system, most in the systemic circulation. So in some detail, let's look at the differences between veins and arteries. And here we're comparing large arteries and large veins. So the innermost layer is always the endothelium. Okay, endothelium being the cells that line all vessels. There is something called a basement membrane, which is an acellular layer that surrounds the endothelium in all vessels, including capillaries. Then we have muscle, and we have connective tissue in various proportions. We have a lot more muscle on the arterial side. We have nerve input because we have to be able to carry those adrenergic signals under a sympathetic discharge. And I think that you don't have to memorize the layers, but kind of have an idea of the importance of vascular smooth muscle, how there's more of it in arteries than in veins, and there's more structure in arteries because this is where vessels have to withstand high pressure, whereas veins, generally pressure is low and they're much less subject to the forces of pressure and flow. As arteries or veins get smaller, you have very similar layers, you just have somewhat thinner layers, always with endothelium and basement membrane. And small vessels, arterioles and venules. Remembering that arterioles are the main source for resistance. Arterioles are extremely subject. They have, again, this smooth muscle which is subject to being that has alpha-1 adrenergic receptors if it is in skeletal muscle, or beta-2 receptors if it is in skin or gut. And then capillaries, which consist of a single layer of cells of endothelium surrounded by basement membrane. Now, we talked about some definitions in the previous lecture. I'm going to talk about some further cardiovascular concepts and definitions that relate less to the heart than to the circulation. So there's a value that is either called flow, F for flow, or it's called Q. And when we get to the pulmonary system, we'll often be calling it Q. So blood flow is the volume of blood that's flowing per unit of time through a given vessel or tissue or organ or the entire network. And if we're talking about total blood flow, then we're talking about cardiac output. There is a pressure generated by the pump that we call the heart, and it's hydrostatic pressure, so it's water pressure, but we measure it in millimeters of mercury, and we call it blood pressure. And it's that pressure generated by the pump that pushes blood through the arterial system and through the capillary beds. There is a difference in pressure between the base of the ascending or aorta, where blood is flowing out of the heart, and the entrance to the right atrium at the vena cava, where blood is flowing into the heart, and that's called circulatory pressure. And given that diastolic pressure is between, so we'll say 120, and venous pressure is, say, 5. That's a significant difference in pressures. This just defines hydrostatic pressure as a pressure exerted by liquid in response to an applied force. So it's the pressure in the liquid that we call blood exerted by the force of the heart pump. Now, if that blood was being pumped just out into the atmosphere, there would be very little pressure, right? Because there would be no resistance. So there is something called resistance, which is a force that opposes the movement of blood, and there is peripheral resistance, which is the resistance in the arterial system, particularly the arterioles, that opposes the flow of blood, kind of pushing back against that heart pump, and is affected by a number of variables that include the resistance in the vessels, which is changeable. If we dilate the vessels, there's less resistance. If we constrict the vessels, there's more. The viscosity of blood, which is actually somewhat variable. Blood that has a lot more cellular components, so high hematocrit, is more viscous. People whose blood is low in proteins like albumin, they have less viscosity, and so you have somewhat less resistance. And then turbulent blood flow contributes to peripheral resistance. This slide introduces a concept called mean arterial pressure, and the mean arterial pressure is computed by this formula. Mean arterial pressure equals diastolic blood pressure. So say if our pressure is 100 here, 138 over, say, 88. So we take our diastolic pressure and we get the difference between our systolic pressure and diastolic pressure, divide that by 3 and add it to diastolic pressure. And this is an important concept because the mean arterial pressure, certainly we have a systolic pressure and a diastolic pressure, but it's the mean arterial pressure that's going to determine whether tissues are getting adequately perfused. And in order to get an adequate amount of blood and oxygen to the brain, we need a mean arterial pressure that exceeds 70. There's also something called a mean systemic pressure. I don't care quite about as much about that. But right atrial pressure here is said to be about 7 millimeters of mercury. And then there's something called TPR, total peripheral resistance, which is determined it's a systemic figure determined by the resistance in the bed of arterioles that supply capillaries. Again, the main site of resistance to blood flow in the system is at the arterioles, and that is adjustable or variable to maintain appropriate homeostasis. Just another diagram showing you kind of the drop off of pressures. This would be mean arterial pressure in the aorta and large arteries compared to the small arteries, a rapid drop off at the arterioles into the capillary bed, and then very low pressures on the venous side. The pulmonary artery and its vascular bed functions at much lower pressures, mean pressures, than the systemic arterial bed. Now, this is a fairly complicated slide, and I don't know how best to relay this, but I'm going to say it, and I'll probably repeat it and say it again. Blood flow to tissues is controlled locally, and so the blood flow that a tissue needs is going to be the blood flow that a tissue gets under normal circumstances. If a tissue requires extra blood flow for some reason, there are going to be local factors that change that blood flow, and they include hormones or paracrines, which are hormone-like substances that work locally, and neurotransmitters, and substances like nitric oxide and histamine. and prostaglandins, and all of these can have local effects on arteriolar and capillary blood flow. There are sphincters in the arteriolar bed that can open and close, smooth muscle basically, that can constrict or relax in response to these local factors like nitric oxide, prostaglandins, inflammatory mediators, things like histamine and interleukins, that act locally to either increase or decrease the flow of blood through the arterioles into the capillary bed. Also, if you think about cardiac output, it's primarily controlled by the blood that's coming back into the heart, so the sum of all the local tissue flow, and preload, which is dependent on the blood that's flowing into the heart from the tissues. If it flows into the heart, it has to be pumped back out. And then arterial pressure is independent of these local factors, and it's independent of cardiac output. And it is influenced by hormones, the parasympathetic and sympathetic arms of the autonomic nervous system, by reflexes that cause vasoconstriction and vasodilation, and by other hormones that are produced in the kidney, in the adrenal gland, even in the brain, and that all contribute to vascular constriction or dilation, along with how the body, including the kidneys, is managing water and salt. And let's just go back to this top one again, because this should come up again and again. Blood flow in a given tissue is controlled locally in relation to the tissue needs. So, for instance, if you are running and need a higher cardiac output to support the blood flow to the skeletal muscles that are helping you run, you're going to have local factors in the myocardial circulation, the arterioles that go directly to the heart muscle, that dilate them and allow greater blood flow within the cardiac muscle. In addition, you're going to have greater blood flow to those skeletal muscles. You're going to have factors going on locally that are going to dilate, that open sphincters, dilate the arteriolar bed that supplies the capillary bed, and so forth. So all blood flow to individual tissues is controlled locally and is based on what is needed at that moment in the tissue. Blood flow is the quantity of blood that passes a given point in the circulation within a given period of time, and that's usually expressed in milliliters or liters per minute. And one example, and the most important example, and the one where I really care that you know the formula, is cardiac output, which is equal to the heart rate. And factors that affect the heart rate include your age, fitness levels, hormones, parasympathetic innervation, autonomic innervation, so parasympathetic and sympathetic, even drugs. All those things feed into heart rate. And if you multiply heart rate times stroke volume, which is the volume of blood being pumped with each beat of the heart, and the factors that affect stroke volume include the size of the heart, the fitness of the person, gender, because males have bigger hearts, contractility, which is inotropy, it's the ability of the heart muscle to contract effectively, the duration of the contraction, the preload, so essentially the end diastolic volume, the amount of blood in the left ventricle right before systole, and then the resistance to flow out of the heart, systemic pressure or afterload. So all of those things affect stroke volume, and cardiac output equals heart rate times stroke volume. This definition of stroke volume is that it's the end diastolic volume, so the amount of blood in the ventricle right before systole or the preload, minus the amount of blood that is left at the end of systole. So it's end diastolic volume minus end systolic volume. And you might remember that there is a value that is the percentage of blood that is pumped out with each stroke. And that value is called the ejection fraction. We're going to talk just a little bit about characteristics of the flow of blood itself. Under normal circumstances, if you have a large diameter vessel with smooth walls and it's a pretty straight vessel, you're going to get something called laminar flow, where the blood flows in streamlines, essentially in layers, with each layer of blood remaining at the same distance from the wall. The velocity of blood in the center of the vessel is always greater than towards the outer edge, so you have this sort of parabola. There are things that can disturb laminar flow and cause turbulent blood flow. So very high velocities result in turbulent flow. Turns in the vessel, so a place where vessels branch off and there's a sharp turn, you can get some turbulence. Rough surfaces, so plaque, deposits of cholesterol on a vessel wall, can contribute to turbulent blood flow. Any place where a vessel changes its diameter rapidly, either increased or decreased, can result in in turbulence. And distortions of valves within the heart through which the blood is flowing can cause turbulence. So why is this important? Well, laminar blood flow is silent, and turbulent blood flow can cause vibrations that we can hear with our stethoscope as murmurs. And those murmurs are very helpful diagnostically. If for instance, femoral artery has a significant cholesterol plaque that disturbs blood flow, we might be able to diagnose that, or at least suspect it, based on hearing a kind of murmur that we call a bruit, B-R-U-I-T, when we put our stethoscope over the femoral artery in the groin. We can hear murmurs when there are abnormalities of valves in the heart. So for instance, a distorted aortic valve might cause a murmur during aortic ejection, during the systole of the left ventricle. As blood is being pushed past that distorted valve, we're going to hear noise. Sometimes if blood is flowing through what's called a shunt, from, say, the arterial side to the venous side, from a high pressure system to a very low pressure system, you will hear turbulent blood flow. And turbulent blood flow really stresses the vessels. So here we have a couple of pictures that suggest to me that the patients died. This first one is an aortic aneurysm. So this is in the descending abdominal aorta, and it's a huge bulging out of the aorta, weakness of the aortic wall that resulted very likely from initially plaque or an irregularity causing turbulent blood flow and pressure differentials that put stress on the wall of the blood vessel, resulting in the aneurysm. And here we have, again, probably an aorta showing all of these cholesterol plaques and irregularities that resulted in turbulent blood flow and additional stress on the aortic wall. This slide is just showing some physics, basically. It has to do with flow through a blood vessel, and that flow is determined by two things: the difference in pressure between the two ends of the vessel and the resistance of the vessel. And that's Ohm's law. Don't memorize it. I don't care. But do know that the diameter or radius of the vessel is the most important contributor to resistance and to flow. So pressure is one thing, but diameter is extremely important. So in this vessel, we have a difference between a 2 centimeter diameter vessel and a 1 centimeter diameter vessel of similar lengths, and the resistance to flow in the vessel that is half the diameter is 16 times. So the diameter of the vessel is extremely important in terms of determining resistance to flow. There are a lot of places in the circulatory system where we have parallel vessels, many parallel vessels, often with the ability there to independently control the amount of blood flowing through any given vascular tissue bed. Blood velocity is greatest in the aorta, and it's very slow in the capillary bed. So remember that that's important. The aorta is important in delivering the blood to the arterioles, but it's important that the capillaries have very slow velocity to allow for the exchange of nutrients and gases in the tissue beds. Again, here's just a diagram showing the effect of the vessel diameter on blood flow. Don't worry about the math. This one is showing how viscosity contributes to blood flow. So the higher the hematocrit, the more resistance to flow that we're going to see. Plasma also has some viscosity. And again, as I said earlier, there are times where a lack of plasma proteins can decrease viscosity and increase blood flow, decrease resistance. Here we're showing a capillary flow in a undefined tissue, showing how the sphincters in the arterioles that supply the capillaries can open or close, allowing either blood to flow, if open, through the capillary bed, or if closed, a kind of shunting of blood directly into the venous system with less blood flow in the actual local capillary bed. And that here is called a thoroughfare channel. So sometimes if the sphincters are closed, we'll have a shunt and we won't get blood flow through the capillary bed. This is very true in some circumstances concerning the lungs that we'll talk about in a couple weeks. And here, in this picture, the sphincters are open and blood is flowing, and in this picture, the sphincters are closed and blood is actually bypassing the capillary bed. And then this slide is demonstrating some different types of capillaries that exist in different organs. Many capillaries are continuous capillaries. The endothelial level consists of cells that have tight bonds between them, and then this non-cellular basement membrane. The endothelial cells of fenestrated capillaries have small pores in them that selectively allow some substances to flow through them. You see fenestrated capillaries particularly in the kidneys and the glomeruli, and we'll talk about those in a few weeks when we get to the kidneys. And then there are capillaries, and I believe the spleen is the site where these are most common, where the junctions between the cells are larger and there are gaps, and where the basement membrane is incomplete. And in a sinusoid capillary, you can have relatively easy movement of cellular elements in and out of the vessels. This again is an illustration of a fenestrated capillary, so likely a kidney capillary. We have endothelial cells. They are tightly bound to each other without gaps. We have pores called fenestrations, which means windows, in the capillary endothelial cells, and here we have a nucleus of an endothelial cell. The entire thing is surrounded by basement membrane, and within the lumen we have red cells, and capillaries are tiny, so these tiny red cells actually need to deform a little bit. They need to be flexible in order to get through those capillaries, and they're moving fairly slowly. This electron micrograph shows a fenestrated capillary endothelial cell. So here we have that endothelial cell, and you can actually very clearly see the fenestrations or the windows, which allow the movement of substances like water, like certain molecules, through the capillary wall. And this is particularly important in the kidneys. Now, we have talked about fluid compartments, and one of the things that clinically is really important to understand is something called edema or swelling. And we have a net flow because there is pressure in the vasculature that is pushing a little bit of fluid always out of the capillaries and into the tissues. And in those tissues, that excess fluid is removed. And it's removed from the tissues by lymphatics. So this is a case where the extracellular fluid that's intravascular is able to escape the vessels and become interstitial, and then it is picked up by lymphatics and ends up intravascular again and getting put back into the venous system. There are things that contribute to edema or swelling. If you have high pressures on the venous side, so the capillary flow has sort of a resistance against it, you can get excess edema. One way that this happens is when people have venous problems that result in incompetent valves in the veins of their lower extremities. That often happens after somebody has had a deep vein thrombophlebitis. It happens when people are on their feet a lot and get varicose veins. So incompetent venous valves can contribute to edema. Another thing that can contribute to edema is decreased viscosity of plasma because of decreased plasma proteins. Proteins in plasma create a pressure we call oncotic pressure. So low protein levels, and this can happen in a couple of different situations. People whose livers aren't functioning synthetically to make albumin and other plasma proteins may have very low plasma protein levels and decreased oncotic pressure. That results in edema. In addition, sometimes people lose plasma proteins. So people with certain kidney diseases whose kidneys are able to allow leakage of albumin out of the blood and into the urine, significant proteinuria, will have decreased plasma oncotic pressure and will get edematous. And then excess pressures on the venous side from things like heart failure. The pump is not pumping adequately, and you kind of get a backup of blood on the venous side, resulting in high venous pressures, and that can cause edema, which is why this one, people with bad veins get swollen legs when they're standing a lot. People with liver disease can get edematous, as can people with certain kidney diseases, and people with congestive heart failure get edema. Just a quick review of pressure and flow, going back to the beginning of our very first lecture, is that we have this balance between venous return that determines preload or end diastolic volume of the left ventricle and cardiac output, and they are the same except in very, very moment to moment short-term differences. When total peripheral resistance decreases, you get an increase in venous return. If you get an increase in venous return, you have an increase in preload. If you have an increase in preload, you're going to have an increase in cardiac output. If total peripheral resistance increases, we have decreased venous return, a decrease in preload, and an increase in afterload or systemic pressure pushing back against the ejection of blood from the heart. There are some terms that are used in regard to heart function and particularly to drugs that we administer to people as cardiac drugs. There are 4 of them. The 3 on this slide that I think are important in that you will encounter them in pharmacology are chronotropic. So chronotropic drugs have an effect on heart rate, either speeding it or slowing it down. And many chronotropic drugs are going to be drugs that are autonomic drugs that are either adrenergic or cholinergic agonists or antagonists. So epinephrine, which is an alpha-1 adrenergic agent, is going to increase chronotropy and increase heart rate. And beta blockers, which are beta-1 and beta-2 receptor blockers, so antagonists, are going to slow heart rate. Inotropic refers to contractility of the heart muscle, and there are drugs that either make the heart muscle contract more effectively or less effectively. And so a drug can have a positive inotropic effect like digoxin, or a negative inotropic effect like calcium channel blockers. And we use these agents or don't use them depending on what we're trying to do. Sometimes we want the heart muscle to be a little more relaxed. So we might want a drug with a negative inotropic effect. Drugs that have a dromotropic effect affect conduction speed, either making impulses travel more quickly through the cardiac conduction system or less quickly. Many drugs that are antiarrhythmics have dromotropic effects. The fourth term is lusitropy, and lusitropy loosely is the opposite of inotropy. If inotropy is about the cardiac's muscles' ability to contract effectively, lusitropy is about its ability to relax. And again, there are drugs that have lusitropic effects. Coming back to mean arterial pressure, which is arterial pressure. The ability of blood to deliver the things it needs to deliver, particularly oxygen, is dependent on the difference between the arterial and venous pressures. So you need high pressure on the arterial side to push that blood through the capillary beds. If the heart stops beating and we are unable to push blood through the capillary system, we don't get delivery of oxygen to the tissues, and that results in death, right? Mean arterial pressure, you saw we had a equation for determining mean arterial pressure that had to do with the systolic and diastolic pressures. But essentially it is also affected by the cardiac output times the total peripheral resistance. So if we leave total peripheral resistance the same and increase cardiac output, we're going to increase mean arterial pressure. If we leave cardiac output the same and decrease total peripheral resistance, we're going to decrease mean arterial pressure, right? And we want it to be around 100 millimeters of mercury. And when it gets much below that, particularly down below 70, we can't maintain consciousness. And we have a ton of homeostatic mechanisms, very tightly controlled homeostatic mechanisms, to maintain that mean arterial pressure at a level where we are delivering oxygen and nutrients to all of our crucial capillary beds. So we're going to talk just for a little bit about some of those homeostatic mechanisms. There are mechanoreceptors that detect pressure and stretch at various points in arterial walls. So at the aortic arch and in the carotid sinus, which is near the bifurcation of the carotid artery, are pressure sensors, stretch sensors that we call baroreceptors. And they collect information basically about changes in blood pressure. If there is an increased stretch or decreased stretch, the number of impulses that are relayed to the brain stem then get sent through the autonomic nervous system to cause changes in sympathetic output to change the conditions in the heart and blood vessels, and also in the parasympathetic output to change conditions in the heart. So it's these receptors are very sensitive to changes in pressure and rate of change in pressure as opposed to absolute level of pressure. So if you have chronic hypertension, they're not firing a whole lot. But if you have a sudden change in blood pressure, say you get a shot of adrenaline that causes a lot of peripheral vasoconstriction that suddenly raises your pressure, then those baroreceptors are going to fire. Or you get shot and you lose a couple liters of blood real fast and you have a sudden decrease in your blood pressure, that is going to be detected and is going to lead to a signaling in the brainstem causing autonomic output. So here we have a little diagram showing the central nervous system, the glossopharyngeal nerve, and probably more important, the vagus nerve, and receptors in the aortic arch, but also in the carotid sinus. And those receptors are sending messages to the brainstem that are leading to changes in autonomic output via the vagus nerve, parasympathetic output to the heart, which will result in a decrease in heart rate if we have increased signaling. So say pressures are higher and you want to decrease cardiac output, you're going to slow the heart rate, which will decrease cardiac output. Or say pressure drops, you may have decreased parasympathetic output so that the heart rate is not slowed, and you'll have increased sympathetic output that will both speed up the heart rate but also constrict blood vessels in arteries and veins, both allowing increased peripheral resistance to main blood pressure, retain blood pressure, and increased venous return to try to maintain preload and cardiac output. So, example, blood pressure increases. Let's say I go to the movies and eat a big bucket of salty popcorn, and suddenly I'm retaining a lot of extra fluid, and my blood pressure goes up. My baroreceptors start sending signals to the cardiovascular control center in the brainstem. Those signals result in an increase in parasympathetic output and a decrease in sympathetic output, which both decrease cardiac output and decrease peripheral resistance, trying to lower my blood pressure. So that's one set of homeostatic mechanisms that's triggered by that big salt load. But there are other important mechanisms, and I'm going to introduce one here which will come up again and again, which is something called the renin-angiotensin-aldosterone system. So, if there is a change in volume such that renal blood flow is reduced, and here let's go back to we got shot and we lost a couple liters of blood pretty fast. So renal blood flow is going to go down because pressures are down and cardiac output is down. So in addition to everything that's going on with the autonomic nervous system, the kidneys start to secrete a hormone that's called renin. The kidneys detect decreased blood flow. And the kidneys are actually an endocrine organ, which not everybody is aware of. So they make a couple of hormones, one of which is called renin. And the renin, as a hormone, is released into circulation. In the circulation, there is a protein called angiotensinogen, and renin interacts with angiotensinogen to turn it into something called angiotensin 1, and then angiotensin 1 interacts with an enzyme primarily in the lungs that's called ACE, angiotensin converting enzyme, and that changes it into angiotensin 2. And angiotensin 2 does two things. One is that it's an extremely potent vasoconstrictor, so it makes arterioles constrict, which increases peripheral resistance. In addition, angiotensin 2 is a hormone that sends a message to the adrenal cortex, causing a release of a hormone called aldosterone. And aldosterone, as a hormone, an adrenal hormone, interacts with the kidneys and makes the kidneys hold on to salt and water, decreasing the loss of water through urine and the loss of sodium through urine, and trying to maintain or increase volume. And then finally, um, the this whole angiotensin aldosterone system interacts with the brain. Um, the angiotensin causes release of a hypothalamic hormone called antidiuretic hormone, or ADH, or vasopressin. And the vasopressin acts as a hormone on the kidneys again, and it causes the kidneys to hold on to water, to not let additional water out into the urine. And also, vasopressin, as its name sounds, is a potent vasoconstrictor, so it increases peripheral resistance. So, that decrease in volume from getting shot and losing a couple liters of blood really fast, a whole lot of things are happening to try to maintain blood pressure, blood volume, and those things involve both the autonomic nervous system and the kidneys. They involve lots of neurotransmitters, lots of hormones, and having an understanding of things like the autonomic nervous system and things like the renin-angiotensin aldosterone system are extremely important in understanding how our systems maintain homeostasis. So this slide is just summing up the renin-angiotensin aldosterone system. We have, let's see, fluid loss that results in a decrease in kidney blood flow. That causes the kidneys to release renin. The renin interacts with a protein made by the liver called angiotensinogen to form angiotensin 1. Angiotensin 1, flowing through capillaries in the lungs and certain other tissues, including the kidneys, encounters an enzyme called angiotensin converting enzyme that turns angiotensin 1 into angiotensin 2. Angiotensin 2 acts directly on blood vessels, constricting them. It's a potent vasoconstrictor. It acts on the adrenal cortex to release aldosterone, which causes a number of things to happen in the kidney, resulting in a decrease of water and sodium loss. Okay. It directly acts on the autonomic nervous system, increasing sympathetic activity, which is also going on through other mechanisms like the baroreceptors. And it's acting on the pituitary to cause the release of antidiuretic hormone, or vasopressin, which again keeps water from leaving the system. It actually returns water from the urinary collection system back into the circulation, so that we hold on to salt and water, and we are trying to increase circulating volume, and so we have a feedback loop. And once volume is adequately back to normal, then we no longer have that decrease in renal perfusion.